Assalamualaikum, it's Dr. Nas. How are you? Good evening. Today we are here with a new topic. As you know that we have done the AVRT, because AVRT is also a type of pre-excitation syndrome. This is a tachycardia because of the pre-excitation. That's why I highly recommend you, highly suggest you guys to please go through my previous videos before listening or before watching to this video. Why? Because if you will not have a good concepts of tachyarrhythmias and the pre-excitation and the AVRT and the ORT and ART, then you will not be able to understand this lecture. So we have to start with the pre-excitation, the WPW. These are the same names of the pre-excitation syndrome and the WPW syndrome, and there's a bit difference between the WPW pattern and the WPW syndrome. If you are having the like pattern on the ECG, as you have is appreciating here, which I have written on the board, right side of the board, that the pattern is a PR when the PR would be short like less than 120 milliseconds and the QRS would be more than 120 milliseconds with delta waves. And what are the delta waves? These are just the upslurring of the R wave, upslurring of the R wave after the P, and it shows it shows that there is something accessory which is making this PR shorter, and it's activating the ventricle before impulse is reaching there. So whenever there would be a delta wave on ECG, it means there's an impulse which is going through here in the ventricle before this AV block sending this impulse here. Then after when you will appreciate that delta wave, it means there is some impulse is going through the accessory wave. That's why we called it as a accessory wave, delta waves and WPW wave. And if you are appreciating this pattern without symptoms, then you will diagnose it as a WPW pattern on ECG. But if your patient has the symptoms with this pattern, then you will diagnose him or her as a WPW syndrome. So the important thing is how this WPW syndrome works, because WPW is syndrome is one of the major cause of the tachyarrhythmias in our cardiac patients. So we will just discuss this in a detail and about this type. As you know that there are the various types of the pre-excitation and the WPW syndromes. So the most common type is AVRT, and we have discussed this AVRT in detail in our last lecture. And we know that the most common AVRT is ORT, which is orthodromic reentrant tachycardia, and there is another tachycardia which is a type of the AVRT, which is ART, antidromic reentrant tachycardia. And we have discussed that the orthodromic are the orthodox, they have to follow the native, their antegrade limb follows this AV node and the retrograde limb goes through this accessory pathway. But in ART, that the antegrade limb goes through this bundle of Kent like this accessory pathway, and the retrograde limb comes through the AV node. That's why we called it as an antidromic, because they are negating, they are opposing the native pathway of our impulse. But the most common type of AVRT in pre-excitation is this AVRT. So that's why we called it as a ART, because it just negating and opposing that native pathway. But keep remember that in pre-excitation, the WPW syndrome, the AVRT is the most common type of the tachyarrhythmia with pre-excitation or WPW. But in AVRT, the most common type of tachyarrhythmia is ORT. Okay, and the less because more than 90% of your patient with the WPW having the ORT, because AVRT is the most common, and in AVRT ORT is the most common and the ART the less common. But these are other types of like dedicated tachyarrhythmias, dedicated type of the tachyarrhythmias with the pre-excitation, such as the PJRT, permanent junctional reciprocating tachycardia, Mahm fiber tachycardia, and low Ganong-Lennon LGL syndrome tachycardia. But now the important thing you have to understand that these all are also the reentrant tachycardias. That's why, and these are also the reentrant tachycardias between the atria and the ventricle. That's why these are the types of the atrioventricular reentrant tachycardia. As you know that what is the meaning of AVRT? The meaning of AVRT is atrioventricular reentrant tachycardias, PJRT, Mahm fibers, and the low Ganong-Lennon syndrome. Okay, so the important thing here is that PJRT, Mahm, Fibre and low Gannon LGL syndromes. But here the PJRT, what is PJRT? We will discuss one by one these all tachycardias. But just keep remember that in all tachycardias, AVRT is the most common type of tachyarrhythmia, which we have discussed in our last lecture. So what is the PJRT? PJRT is like the same atrioventricular reentrant tachycardias, but the important thing here is that it is just like ORT, because here antegrade limb is following this AV nodal, there is a normal pathway, and the retrograde limb is going towards the accessory pathway. But here the bundle of Kent, because these accessory pathways are used to be known as bundle of Kent, we called it as bundle of Kent in the past, but nowadays it is known as, and it is written as a accessory pathways. So you can tell it, you can call this it as a bundle of Kent. So here this PJRT is same is like the ORT, but there is only one difference, that this accessory pathway behaves like AV node, as AV node has a capability to decrease the response, to send to give a decremental response to further structure. When there would be a atrial fibrillation, then AV node just blocks all fibrillation and send just few impulses to this ventricle. Same as here, when there would be a major impulses, when there would be a major like signals or more impulses going towards this accessory pathway, then this accessory pathway behaves like AV node in the PJRT tachycardia, the PJRT, and it sends very little response. As you are appreciating, there are more arrows, and it is allowing just a few or one arrow towards this left atrium. So this type of tachycardia is known as a PJRT in the permanent junctional reciprocating tachycardias. Then the Mahm Fibre tachycardia. What is the Mahm Fibre tachycardia? Mahm Fibre has actually two types of tachycardias. The one is actually two types of the pathway. One is the AtrioFascicular pathway, in which, and these Mahm Fibre are most of the time are the right sided, are associated with the right sided pathway. So in AtrioFascicular Mahm Fibre tachycardia, and there is a FasiculoAtrial Mahm Fibre tachycardia. In AtrioFascicular Mahm Fibre tachycardia, this accessory pathway is present at the right atrium, and this antegrade limb is going towards this right atrium, and it follows and it comes through this AV node. And that second one is a fasciculoatricular accessory pathway, in which there would be accessory pathway would be at the right fascicular, and this it would send the impulse, it would would be activated, and it would be activated. That accessory pathway would present at the right fascicle, and it send impulse to upward towards that AV node, and that type of the Mahm Fibre Mahm Fibre variant is not clinically significant, because it does not create tachyarrhythmias most of the time. That's why this is not worth discussing. But you have to remember that the atriofascicular tachycardia, in which there would be a accessory pathway would present at the right atrium, and it would send impulse towards the right ventricle through this accessory pathway, and then the retrograde limb comes through this node. Now that the last but not the least, we have a low Gannon Lennon LGL syndrome, or the low Gannon Lennon tachycardias. So LGL syndrome is like the obviously it would have a same WPW pattern in your ECGs, but the important thing is that in low Gannon Lennon syndrome, the accessory pathway is buried inside the perinodal area. Perinodal area is like most of the time they presented in the perinodal areas, so you cannot actually differentiate that is it a pathology of the AV nodes, or is it the pathology of the accessory pathway, or is it associated with the pre-excitation or the WPW syndrome. But obviously if that it would have accessory pathway even in the perinodal area, again that it comes into the domain of accessory pathway or accessory pathway. That's why in LGL syndrome it is actually accessory pathway in the perinodal area, and there would be a re-entrant inside the AV nodes. That's why you can again tell it as it can be associated with the AV-NRT, AV nodal reentrant tachycardias. Now the important thing, how you will manage it, we have discussed AV-RT and ORT and the ART, how we will manage it acutely or in the chronic forms in our previous lectures. In PJRT, you know that there is like a decremental response of this, then you have to it behaves like AV node, then you have to ablate it. So the ablation is the procedure to do this. And again, the Mahm fiber, this FasiculoAtrial variant is not clinically significant, then you do not have to do anything. In the AtrioFascicular and the Mahm fiber tachycardia, you have to do the accordingly, according to your WPW, your criteria, to because in which we will discuss in our coming time, in which very soon, that how we will risk stratify our asymptomatic patients, and those are the patients who are actually candidate for the ablation. So obviously you have to follow that pattern, but again here you have to ablate this Mahm fiber, that AtrioFascicular Mahm fiber tachycardias. And LGL syndrome, there are very less chances to ablate that, because this is very near to the AV node, and if you are actually going to ablate it, then you have to make preparation of device, because your patient may go into the AV nodal block. How you will localize the pathway on the ECG, there are the Aruda criteria, which is actually very typical and very difficult criteria. I will make a separate lecture for localization of the pathway on the WPW syndrome, but now onwards just you have to remember that how you will localize. You just can localize on ECG the best thing, that where is the accessory pathway present, right side or the left side. So just keep one thing in your mind, that in ART, in ART you will have the right complex tachycardia secondary to pre-excitation, and in that ART you would have a bundle branch block of the ipsilateral to the accessory pathway. So if your accessory pathway in ART, like if your tachycardia is going on, then in the ART, if your accessory pathway is present at the left side, then obviously its antegrade limb goes through this accessory pathway. Then when it goes through this accessory pathway, it actually blocks that fascicular of the same side where this accessory pathway is present. That's why in ART, the tachycardia going because of the pre-excitation, you would have the ipsilateral bundle branch block of the where the accessory pathway is present. But on the resting ECG, if your patient has accessory waves with the no tachycardia and the accessory waves most of the time, then you would have the contralateral bundle branch block, then your where the accessory pathway is present. For suppose if the accessory pathway is here, and if it is activating here from your if your ventricles are activated through here, then the impulse would be propagated through the right side, then you will have the LBB. So just keep one thing in your mind, that in ARTs you would have a ipsilateral bundle branch block with the pre-excitation, but on the ECG, on the pre-excitation, on the ECG with the pre-excitation, if you have a RBB, it means that your pathway is on the left side, because your heart is activating through the left sided. That's why you would have a RBB, as we would have a LBB in the RV pacing, because in the RV pacing you just pace the heart through the right ventricle. Same as here, if you have a LBB, it means you are pacing your heart through the right ventricle, so it means your pathway is on the right side. So there is a difference between the ART and LBB bundle branch block in the ART and the bundle branch block in the resting ECG of the pre-excitation. Okay, so those were the things, and there are again more things to discuss with this Aruda criteria, but Aruda criteria is actually very difficult and very complicated one, so I just don't want to make you complex and the more make you confused here to understand this WPW and the pre-excitation. So I have just made it very simpler for you. Just remember that RBB and left sided on the right sided, then and keep one thing more, that on ECG there are the specificity of 90 to 95% with the Aruda criteria, and the sensitivity of the 90 to 95% with the Aruda criteria. But again, the most precise method to locate the pathway is your EP study. Okay. So again here now the management of the pre-excitation in the WPW syndrome, as we have discussed the types of the WPW pre-excitation or accessory pathways. Now here few are the management of the symptomatic when the patient comes to you in the ER with the symptoms, and when you need acute termination of the that tachyarrhythmias, and there are the some chronic medical treatment of your like the chronic condition of the patient with the WPW syndrome and he or she has the symptoms. So first I think and then obviously those are the patients who are asymptomatic, and there would be an incidental finding of the WPW or pre-excitation on the ECGs. Now the important thing here, the symptomatic in the ER, what would you do then in the if the patient is symptomatic in the ER? Then now the important thing is that is patient diagnosed with WPW pre-excitation, or is patient is not diagnosed, because sometimes patient is coming to you with the AVRT or narrow complex tachycardias and they are most of the time not diagnosed with the pre-excitation. Then you have to treat them with, if they are narrow complex tachycardias, then obviously you have to treat them with AV nodal blocking agents, adenosine and the calcium channel blocker, and with the atrial pacing as you treat with the AVNRT and the AVRTs. But if your patient is diagnosed pre-excitation, then it is better not to use these AV nodal blocking agents, because they cause the atrial fibrillation. 15% of the patient they cause the atrial fibrillation. Why? Because when there were in heart for suppose there is this is AV node and this is accessory pathway. If patient is in tachycardia and because of atrial fibrillation, the important thing is that when there would be a narrow complex tachycardia with irregular RR complexes, then it is better not to diagnose. And if keep one thing in your mind, that in narrow complex is patient normal RR like regular RR or irregular RR. Now the important thing which I actually want you to understand, that in narrow complex tachycardia, if your patient is diagnosed pre-excitation, then it is better not to use these drugs. Why? Because whenever you will use these drugs, either your patient is in the regular RR or irregular. If it is irregular RR, then it is contraindicated to use these drugs. Why? Because when there is a atrial fibrillation in atrias, then obviously there are something going on through this AV node, and AV node is blocking that atrial fibrillation. But when you will block that AV node, then this all atrial fibrillation would pass through this accessory pathway and cause the VFVT. That's why it is better not to use these AV nodal blocking agents in diagnosed pre-excitation, and especially when there would be irregular RR narrow complex tachycardia. Why? Because probably that would be a atrial fibrillation with pre-excitation. Now the most important thing which actually here most of the time I just want you to remember that but if there is a regular RR complex and there is no history of pre-excitation, patient is coming to you, you can use AV nodal blocking agent then. But again, you have to keep one thing in your mind, that if your patient would be patient of pre-excitation, he or she has a chance, 50% chance to go into the atrial fibrillation with that pre-excitation when you will block the AV nodal blocking agent. Okay, but so now what would you do when your patient is coming to you with wide complex tachycardia and so here symptomatic but hemodynamically stable? These both patients are hemodynamically stable. Okay, the hemodynamically unstable will patient here at the last. So just keep remember that these patients are hemodynamically stable. With the wide complex tachycardias, if your patient is hemodynamically stable and he or she has a history of pre-excitation, then never ever use these drugs, AV nodal blocking agents such as calcium channel blockers and your beta blockers and digoxin. So but the drug of choice to use in the wide complex tachycardia in the diagnosed case of pre-excitation is procainamide. Okay, otherwise if your patient has a history of wide complex, if your patient has a history of MI and he or she is presenting to you with the wide complex tachycardia and you are looking that your patient is hemodynamically stable, then amiodarone is a drug of choice, you know it. But in all or in any condition, if your patient is symptomatic and unstable, just DC cardio with it. That's all. Don't use these drugs or anything else. If your patient is symptomatic in ER and he or she is unstable in the ER and he or she is becoming hemodynamically unstable, then you have to just DC cardioversion with the you have to do the just synchronized cardioversion at least 200 joules. Okay, so okay, if your patient is asymptomatic and there is an incidental finding, then you have to look for the high risk features. What are the high risk features? Family history, sudden cardiac death, family history of sudden cardiac death, age less than 30, male, history of VT, like history of how would you take your history. You have to take the history of the syncope. If your patient has syncope, which is most likely because of the ventricular tachyarrhythmias, then this is an other risk factor in your patient. So multiple pathways is another like risk factor. Atrial fibrillation on ECG or exercise tolerance test, RR, if your RR interval on ECG is less than 250 millisecond, and number 2 is if you are sending your patient to the ETT to check the response of the pre-excitation, and if there is an intermittent loss of the pre-excitation, then this is a low risk patient. It shows that your patient is low risk. But if your patient has no loss of pre-excitation on exercise tolerance test, ETT, then it is another high risk feature for pre-excitation. So short refractory period, if on EP study there is a less than 250 millisecond less than 250 refractory period of less than 250 on EP studies is another high risk feature. And if there is a high risk profession and their patient is an athlete or a participant of the competitive sports, then again it is a high risk features. Why it is important, we will discuss later on. So you have to treat your patient with the chronic medical treatment. Those who are the candidates who should be treated with the chronic medical treatment, those who are the high risk but with no symptoms, like these are the patient asymptomatic but there is no symptoms, then it is better to treat them with the medical therapy. So you have and what are other patients? Those patients who have like high risk for the accessory, if they are like LGL syndrome, in which your accessory pathway is buried inside the AV node, and then when you will do the ablation, they would go into any other disease or like AV nodal disease, and you just want to keep your patient on medical therapy, you can keep your patient on the medical therapy. Now the important here is the second thing is that those patients who don't want to go with the radio frequency ablation, or those patients who are actually contraindicated to go for the radio frequency ablation, such as very high for like any condition for which they could not go through this radio frequency ablation, then you can treat them through single drug therapy or double drug therapy. Single drug therapies are the amiodarone, sotalol, propafenone, and the flecainide. So these are the drugs like these are the class 3 drugs and 1A drugs. 1C drugs. Propafenone and flecainide are the 1C drugs, and amiodarone or sotalol are class 3 drugs. Okay. So if you want to treat with your double agents, then you have to give this AV nodal blocking agents such as a calcium channel blocker and beta blockers, and in double combo you have to use those drugs who are dedicatedly work on who could work dedicatedly on your accessory pathways. So there are only 3 drugs of the 1A which dedicatedly work on your accessory pathways. They actually decrease the conduction through your accessory pathway, but increase the conduction through AV nodal pathway. That's why you have to give the AV nodal agent, because when you will not give that AV nodal agent in those patients, then what would happen? The all impulse through the AV nodal will be increased, and if your patient would have atrial fibrillation, that might go into the tachyarrhythmias. That's why you have to block the AV node agent as well as that accessory pathway. So quinidine, disopyramide, and procainamide. One thing just you want to more that these propafenone and flecainide, these are the agents which also increase the conduction through AV node. So if you actually want to start these drugs on your patients, so before starting these drugs you have to keep your patients on beta blocker agents. Okay, so this was the pre-excitation WPW, but now not the least, those who are the patients who are actually candidate for the radio frequency ablation. So the success of the radio frequency is 80 to 90%, but the recurrence rate is 15 to 20%. 15 to 20% would again go into the accessory pathway syndrome or WPW syndrome because of these accessory pathways. So those who are the patient, those patients who are high risk features, those patients who would have like 3 to 4 or more than 3 to 4 high risk features, then they should go for the radio frequency ablation. And especially high risk professions such as pilots, school bus driver, they should go for the radio frequency ablation because their life is actually dependent, like so many people's life has been dependent on those high risk professions. So number one is symptoms despite of medical therapy, like you have tried all these drugs but your patient is despite of all these things, or he is intolerant to these drugs, or he is unable to take these drugs, or if he or she has taken these drugs but there is no response, then you have to do the radio frequency ablation. But you have to remember one thing, that there are so many complications of radio frequency ablation, such as the fistula, such as the AV nodal blocks, and such as the recurrence of that disease. So we have done here the pre-excitation, the WPW, and inshallah in our next lecture we will start the ventricular arrhythmias, and we will do one by one all the ventricular arrhythmias. And here I just want to thank you guys for giving me such a wonderful response, that thanks again. So just subscribe my channel and press the bell button for the future videos. Thank you. Allah Hafiz. Take care.